Bismillahirrahmanirrahim. Let's we start our today's lecture number third, cardiology, conducted by the AMC Prep Academy. So today's topic is very important, cardiomyopathy. Many questions in every month exam. So let we start about cardiomyopathy. What is cardiomyopathy? This is a broader term used to describe the different condition of the heart. So firstly, what is it and what is the condition which is described by cardiomyopathy? For example, here we differentiate between cardiomyopathy. We have dilated cardiomyopathy and restrictive cardiomyopathy. Here, Dr. Fatma, I will explain in Urdu. Don't worry. Cardiomyopathy, dilated cardiomyopathy. Firstly, try to understand what is it. Dilated cardiomyopathy and hypertrophic hypertrophic obstructive cardiomyopathy. Cardiomyopathy, also known as HOCM. So, and as well as we have restrictive cardiomyopathy included over there. So the important one is hypertrophic obstructive cardiomyopathy. Very, very important from exam point of view. This is very, very important. So one by one, we will discuss what is dilated cardiomyopathy. In history, presentation, clinical feature. The patient presented with dyspnea on exertion, edema, edema on feet, ankle. This is also known as systolic heart failure, as we discussed in our last class. Systolic heart failure. And this hypertrophic obstructive cardiomyopathy, also known as diastolic heart failure. And the almost treatment is same. The thing which is different, we will explain. So this will be in dilated cardiomyopathy, dyspnea on exertion, edema in hand and feet, because here is heart failure. And as well as there is a raised JV, jugular venous dissension, S3 and S4 gallops, uh, you will hear, along with mitral and tricuspid regurgitation. So this is the clinical feature. What is the cause? What is the cause? In cause, might be the patient have history of upper respiratory tract infection, viral infection history, viral infection history. Might be due to any Kawasaki virus or adenovirus. This will be in the history. And patient have upper respiratory tract infection a few days ago, and later on presenting with post-viral myocarditis. So this will be included in history, but most of the time history is unknown. I mean, cause is unknown etiology. And some cases alcohol is also cause. But mostly cases, 80% cases, etiology is unknown. What is the investigation? How to diagnose DX? First line, always ECG. If ECG is inconclusive, then it is initial test. Initial is ECG, and best test. Ask appropriate test. Any term which use in exam. This is echo. And for adjunctive, we will do the chest X-ray. And in chest X-ray, you will see the balloon-like heart. This is adjunctive we will do. Balloon-like heart. What is the treatment? Treatment will be same like systolic heart failure as we discussed in the previous class. Systolic heart failure. Doctors, it is understandable. Any question? नो दी आई एम क्विकली रिवीजन इन दी उर्दू. डायलेटेड कार्डियोमायोपैथी का जो पेशेंट होगा वो आपके साथ डिस्निया ऑन एक्सर्शन, जब वो मूव करेगा और उसको डिस्निया होगा, एडीमा होगा फीट पे, एंकल पे, जुगुलर वेनस डिस्टेंशन होगी, और S3 S4 गैलूप्स आपको सुनाई देंगे, और साथ में रिगर्जिटेशन होगी. और हिस्ट्री में क्या होगा, पेशेंट कहेगा कि मुझे फ्यू डेज पहले कोई वायरल इन्फेक्शन हुआ था, अपर रिस्पिरेटरी इन्फेक्शन हो सकता है. तो उसके बाद पोस्ट MI मायोकार्डाइटिस होगा. ठीक है, पोस्ट वायरल मायोकार्डाइटिस. तो उसमें कॉज जो होती है मोस्टली 70 to 80% कॉज इज अननोन, लेकिन फ्यू केसेस में अल्कोहलिक और कोई वायरल कॉज भी हो सकती है, बट मोस्टली कॉज इसकी अननोन है. डायग्नोज में फर्स्ट लाइन जो होता है वो ECG करते हैं, और जो बेस्ट होता है वो एको करते हैं. और चेस्ट एक्सरे अगर करते हैं तो इस पर बलून लाइक हार्ट नजर आता है. और ट्रीटमेंट इसका सेम है जो हमने हार्ट फेल का किया था, सिंपल. डॉक्टर्स, एनी क्वेश्चन? डॉक्टर फातिमा और दूसरे सब, एनी क्वेश्चन? ओके जी, ओके. ओके. नो, we will discuss about the hypertrophic obstructive cardiomyopathy. This is important from exam point of view. So what is the HOCM? You will, I think, know about the HOCM. जी डॉक्टर अमर भट्टी, ट्रीटमेंट हमने हार्ट फेल का उस दिन स्टेप वाइज किया था कि एट अ टाइम हमने एसिन इनहिबिटर और बीटा ब्लॉकर डायूरेटिक्स वगैरह ऐड करने होते हैं अकॉर्डिंग टू सिचुएशन. और अगर कंजेस्टिव स्टेट होती है तो उसके अंदर हम बीटा ब्लॉकर ऐड नहीं करते. अगर कंजेशन हो, जब कंजेशन यूवोलिमिक पेशेंट होगा तो फिर हम बीटा ब्लॉकर ऐड करते हैं. मतलब A B D इस तरह से याद रख ले. एसिन इनहिबिटर या अर्ब्स, फिर उसके बाद बीटा ब्लॉकर, देन डायूरेटिक्स, और इस तरह स्टेप वाइज. वो हमने यस्टरडे क्लास में किया था. So now we will discuss about the hypertrophic obstructive cardiomyopathy. This is important, and in clinical feature, this is often asymptomatic. Most of the time, this is asymptomatic. But uh, sometime in most of minority of the patient present with syncope, lightheadedness, sometime lightheadedness and dyspnea, palpitation sometime. And in patient history, patient will tell you that he has a unconscious suddenly and again regain conscious state suddenly. Mean to say, patient goes in unconscious state, and and after few minutes again regain conscious. So this is in the history in case of cardiac syncope. But in case of uh, any neurogenic syncope, the patient will not regain at this spot. He will take time to regain. So in this case, and might be in some cases, there is sudden death. And in history of patient, there is family in young age family member death due to sudden death without any cause. So in this case, you will think might be the patient in 30 year of age, 30 year of age, and family history is positive, positive in case of like death in earliest and youngest age, and you will think it is hypertrophic obstructive cardiomyopathy. And also the patient will be athlete. So when the patient presenting with you with the history of sudden blackout, syncope, lightheadedness, dizziness, you will think it is might be in youngest age, and patient profession is athlete, you will think it is hypertrophic obstructive cardiomyopathy. And when you ask about the family history, and he said yes, in earliest youngest age, few member death suddenly without any cause. So this is hypertrophic obstructive cardiomyopathy. What are the investigation investigation? The same as we discussed. You will do the ECG. Firstly, ECG is initial. All heart condition, the initial thing is ECG, initial ECG. And best will be the echo. Echo will be diagnostic, the same as diastolic. So this is the thing you need to know. And treatment will be beta blocker or calcium channel blocker. So this is the treatment because in hypertrophic obstructive cardiomyopathy, there is heart is too much contracting. Systolic function is fine, but diastolic function problem. So we will block the heart contractility by giving the beta blocker or calcium channel blocker. So this is the things you just know. Beta blocker or calcium channel blocker, simple treatment, and diastolic. In case of dilated cardiomyopathy, the treatment will be heart fail as we discussed. So the quick revision summary, हाइपरट्रॉफी ऑब्स्ट्रक्टिव कार्डियोमायोपैथी का पेशेंट आपके पास आएगा तो हिस्ट्री में देगा कि वो एथलीट है, और सडन जो है ना सम टाइम वो बेहोश हुआ और फिर उसने अगेन वो कॉन्शियस हो गया, और सम टाइम वो ये कहेगा कि लाइट हेडीनेस भी उसे फील हुई, पेल्पिटेशन वगैरह भी ये भी हो रहा था, लेकिन वो रिजॉल्व हो गया। और सम टाइम ऐसे और हिस्ट्री में देगा कि हमारी फैमिली के अंदर सडन कार्डिक डेथ की हिस्ट्री भी है इन यंग एज, 25-30 ईयर, इस एज के अंदर डेथ भी है। तो आपका जो डायग्नोज होगा वो हाइपरट्रॉफिक ऑब्स्ट्रक्टिव कार्डियोमायोपैथी होगा। और इसके लिए जो इन्वेस्टिगेशन होगी वो ईसीजी, और बेस्ट जो होगा एको। और जो ट्रीटमेंट आपने करना वो बीटा ब्लॉकर, या फिर आपने उसके साथ कैल्शियम चैनल ब्लॉकर ऐड कर दे। क्यों? क्योंकि हार्ट की जो यहाँ पे जो सिस्टोल फंक्शन है वो ठीक है, डायसिस्टोल फंक्शन फेल है, क्योंकि हार्ट रिलैक्स नहीं कर रहा। तो रिलैक्सेशन ना होने की वजह से उसको उसमें ब्लड जो आ रहा है वो बहुत कम आ रहा है, और वो कम आने की वजह से जो बॉडी की मीट है उससे वो उसके जो बॉडी की डिमांड है उसको उसके लिए इनफ नहीं है। तो इसके लिए आपने फिर ब्लॉकर देनी है, बीटा ब्लॉकर, ताकि जो कंट्रेक्टिलिटी या हार्ट की वो ब्लॉक हो। डॉक्टर्स, डज इट मेक सेंस? एनी क्वेश्चन डॉक्टर्स? Doctors, hurry up, please. We have a lot of things to do. Okay, okay. So, quick summary we will see here. What's written over there? This is from Kaplan step to CK. So, the things we discussed already: dilated cardiomyopathy, hypertrophic cardiomyopathy, and this is restrictive. The important things which you know, it is hypertrophic obstructive cardiomyopathy. Very, very important. So, the important things I will highlight it you. So, don't skip this. This is very important. This is dilated also you will read, but the most important hypertrophic, and restrictive very least important. No single question I saw so far in recalls, but you should know. So the things in dilated, justly we will see the cardiac output. In dilated cardiomyopathy, you will see here, this is the normal heart. You will see, this is the normal heart. And in dilated cardiomyopathy, you will see the size of heart is enlarged. This cavity enlarged. Yeah, this cavity enlarged. But here you will see this is the normal cavity. So dilation. The problem is contractility, no contractility. No contractility. I mean systolic failure, systolic heart failure. No contractility. So this is so due to the systolic heart failure, there will be decrease cardiac output and decrease ejection fraction. So this is the mechanism. Cardiac output will be decreased, but in case of hypertrophic obstructive cardiomyopathy, there will be normal or mildly decreased. But the ejection fraction, you will memorize ejection fraction or output is normal. Let's see here. This is the normal heart in case of hypertrophic cardiomyopathy. Normal heart. But in case of hypertrophic, there is hypertrophy of the intravascular septum, hypertrophied. It blocks the outflow of left ventricle. It is aorta. This is aorta. This is intraventricular and there is thickness. This is hypertrophied muscle and there is you can see left ventricle, very small cavity. Left ventricle, small cavity. And here you can see this is the normal ventricle and this is the normal space. But due to the hypertrophied ventricular thickness, it blocks the outflow of the left ventricle, so decrease blood supply to aorta. But systolic function is normal. So this is the way. Doctors, it is okay. This is the mechanism, pathophysio, how it is goes on. This is outflow obstruction. So let's see here. Let's see here. Cardiac output will be normal. Okay. Stroke will be decreased. Stroke volume will be decreased. But here in case stroke volume normal, we discuss all the things. Ventricular pressure will be increased. Here normal or decreased. Chamber size in dilation, we see here the chamber size. The chamber size increase. This is the chamber size. This is. But in case of hypertrophic, the chamber size will be decreased. Ejection fraction in dilated decrease, but in case of hypertrophic, it will be increased. Diastolic. So this is the thing we already discussed. And in case of restrictive cardiomyopathy, there is the systolic and diastolic both heart are fail. So let further we will discuss. And this is dilation. I think you can read it's your own time. This is the things. And just quickly, dilated cardiomyopathy usually involve both ventricle, common cause of heart transplantation, and mostly it is idiopathic. 80% idiopathic, and sometimes alcohol will be cause, and some post-carditis due to infection will be cause. Toxin, doxorubicin, metabolic causes as well, and clinical feature will be the symptom and sign of the left and right ventricular failure, typical systolic failure, you just know. And diagnose will be ECG. ECG, we will see this is pulmonary congestion, and ECG will be the first line, and echo will be best, second best, and this is the initial. This is the way AMC asks question: what is initial, what is the best? And treatment, those who like the heart failure, the same treatment, ACE inhibitor, beta blocker, spironolactone. This is the thing we already discussed. And if the ejection fraction will be less than 35 and we will at the end replacement of valve implantable defibrillator we will use. This is the device we use. Move to next. So hypertrophic, I am reading this concept. We already discussed hypertrophic obstructive cardiomyopathy. HOCM. This is the one more important thing. This is autosomal dominant. Autosomal dominant. This will be question. This will be recall as well as autosomal dominant. Because family is positive and dominant mean 60% it is hereditary and 60% of cases and transmitted autosomal dominant traits. This is the thing. And pathophysio hypertrophy of the left ventricular compliance, not depressed, diastolic dysfunction is affected, result in decreased compliance, and the heart is hypercontractile because contractility is preserved, systole function is preserved, diastolic problem, and systole occur with striking rapidly. Ejection fraction will be often 80 to 90%, normal 60 to 60, 55, 60. So this is the thing we discuss. Clinical feature we discuss: dyspnea, angina, syncope, palpitation, exertion. Sudden death in some time be a first manifestation. And diagnose will be ECG and echo will be best. So treatment, beta blocker or calcium channel blocker. Just need to know. Beta blocker or calcium channel blocker. This is the thing. And clinical, one more important things in hypertrophic obstructive cardiomyopathy, there we need to advise patient don't be dehydrated, stay always hydrated because here is output problem. So already decrease output sometime. Ejection fraction is normal, but decrease if you give the direct diuretics and it will be more goes in depleted state. So we will advise to avoid the diuretics. This is the question. Doctor, so far move to next. And so far you have any question? Doctor, please reply. Dr. Aman, Dr. Fatma, any question, please? Okay, okay. Restrictive cardiomyopathy. This is quickly I will read in which there is problem of systole and diastole. Both heart fail, systolic and diastolic dysfunction. Simple. Systolic dysfunction. I mean forward and backward both heart are fail. Why? Because there is, you can see the wall of ventricle becomes stiff. There is stiffness. This stiffness might be due to the amyloidosis or sarcoidosis or hemochromatosis. This is the thing. Any other causes which lead to the stiffness of this wall. So this is restrictive in which both systolic and diastolic dysfunction. And the patient will be presenting with the both heart fail, like right heart fail symptom as well as and left heart fail symptom as well as both symptoms, as we discussed already in our heart fail class. Both sided symptom. Raised JVP and in right arterial edema, pulmonary edema, something the things we discuss in detail in our class. Pulmonary edema, dyspnea, like this. So let's see, and a diagnosis will be same. Investigation, same. ECG initial, and echo best. This is the thing. Let adjust. We will see what's written here. Restrictive least common. Book is also mentioned least common cardiomyopathy. So etiologies will be sarcoidosis, amyloidosis, hemochromatosis, neoplasma, scleroderma radiation. Pathophysio. This will be myocardium rigidity, decrease compliance. Systolic performance often reduced and diastolic also problem. So clinical manifestation, dyspnea, exercise intolerance and weakness. Diagnose will be X-ray in which we will see the cardiomegaly, EKG will be initial and echo will be confirmatory. Treatment is, this is very alarming condition. So no good therapy for this and usually result in death from congestive heart failure or arrhythmias and then heart transplantation. So this is not very important. So